Oh,
Welcome, Mr. Virgil.
how's everybody today?
I'm good. How are you, Virgil?
Oh, a little slow, but that's when you get this old, that's what happens to you.
I feel that too. My gosh.
Need some sunshine.
Yeah, I'm a little tired of the rain. Has it been raining a lot in New York City?
Yes,
At
It
least it's
has.
at night for here in Topeka. I don't know about there.
It's been all morning this morning, off and on. Kind of a gloomy day.
I keep worrying about the mosquitoes that
Yeah,
are going to come.
my neighbor doesn't have good water drainage, so he's got puddles, and the mosquitoes are everywhere.
I
Down
have a
at my
neighbor.
son's too. My granddaughter's got a new pool, and the mosquitoes are trying to eat her up.
Ugh, it's awful. I have a neighbor like that too. So nice to see everybody. I'm going to start right at the top of the hour to get the announcements that I have to make out of the way so we can have time. Okay, it's noon, so we'll get started. So hi, everybody. Welcome to the June meeting of the Kansas COVID Vaccine Equity Task Force. So nice to see all of our regular members, and also I want to welcome any new participants. So I have a couple of announcements before we begin. I need to share that COVID operates in compliance with the Kansas Open Meetings Act. This meeting is being recorded and live streamed on KDHE's YouTube channel. I ask that you please mute yourself when you're not speaking to prevent audio interference. So my name is Jimena Garcia, and I'm the governor's senior advisor for COVID-19 vaccine equity. I'm going to be leading this discussion today together with my friends and colleagues from KDHE, Courtney Hayden, and Dr. Vicky Colley Akers from KU. Again, I'm excited to see everybody today, and I'm actually really excited about the meeting that we have planned. Before we walk through the agenda, I wanted to ask for your feedback. So I would like to move the meeting from this exact time going forward because we're finding several conflicts and we have many members that are not able to attend at this time. So what I'd like to ask of you is that you fill out a little link that we're going to put in the chat with some other meeting times, and ask that you fill it out so we can choose an alternate time that works for the majority of the group. So that'll be in the chat. So without further ado, we could get started. If you don't mind, please to put up the agenda. Perfect. Okay, so I'm just going to do a quick review of the agenda. So as usual, we're going to start with a moment for any quick introductions from new members. We're then going to move to the COVID vaccine update. And I'm excited to say that today, the COVID vaccine data is going to be presented by a special guest, Jamie Gable, Senior Epidemiologist at KDHE. Following the vaccine data update, we're going to hear from another special guest, Dr. Dana Hawkinson from KU will share with us new information about COVID vaccines and also about long COVID. Our PAVE Spotlight this month will be presented by Giovanni Gone of Genesis Healthcare. And then later in the hour, we're going to spend a little time reviewing the findings from the discussions that the work groups have had over the last few months, and then finish up with a quick preview of what is coming next for the task force. Our next unit is going to be public health in the context of a pandemic. And then after that, I'm going to open up the floor for a few minutes to hear from anybody who wants to give any updates or upcoming events or announcements, and then we'll wrap up. So if you don't mind taking down the agenda, I wanted to just do a quick intro. So I'm not positive if we have anybody new, but if you are attending this meeting for the first time today, would love to hear from you. Please tell us your name, organization, and your GLOW, which is 5 words or fewer describing something you are passionate about. And if you are a regular member of COVID, please put your name and organization in the chat. So do we have anybody new today?
Hello, I'm not new. I just haven't been able to always get on a little bit late. But my name is Jaquan Heron. I am the Diversity and Inclusion Manager for the Alzheimer's Association. My job is to bring resources, tools, and support to our underserved and diverse communities here in our 65 counties in the state of Kansas and Missouri.
Wow, that's a big job. Thank you.
Thank you.
Good afternoon. Like Wakan, I've attended in the past, but it's been a very long time. I'm Karen Brayman, Senior Vice President for Clinical and Strategic Initiatives with the Kansas Hospital Association. I believe our President and CEO, Chad Austin, has been joining, but I'm glad to be back involved with the group. That's a tough one. What is your GLOW? But I'm going to say it's KHA's vision, which is optimal health for Kansans. Thank you.
Well, thank you. Thanks, Karen. Anybody else?
I'm not new, but I think this is my first time attending. Rosalind Brown, and I am with the Kansas East Jurisdiction Church of God in Christ at Miracle Temple. And we have been working diligently with Wyandotte County in trying to make sure that everyone has the opportunity to be tested and get their vaccination, and whatever we can do, we're trying to be a part of it. Thank you.
Wonderful. Thank you, Rosalind.
Good afternoon. I'm Giovanni Gone. I am the Chief Administrative Officer for Genesis Family Health. We are a federal qualified health center in Western Kansas. I would say my GLOW would be serving the community. It is definitely one of my I'm very much passionate about it.
Thank you, Giovanni.
I'm Brenda Bandy, Co-Executive Director of the Kansas Breastfeeding Coalition, and this is my first meeting. We have a new campaign, Protect Yourself, Protect Your Baby, to have open, honest conversations with new mothers about the vaccine.
Wonderful. Welcome.
Hi, I'm Paige Lewis. I work with Immunize Kansas Coalition, and I do social media and communications. And I would say my GLOW is finding different communication efforts to serve underserved populations.
Thank you, Paige. Okay, well, thank you everybody for sharing and the introductions. I guess we can move into the meat of the meeting. So I'd like to begin by introducing Jamie Gable, Senior Epidemiologist at KDHE. So grateful to have you here today to share vaccine data and also explain where the data comes from and how it might look a little different from the data that we have been seeing today and then going forward. So I'll pass it to you, Jamie. Thank you.
Thank you. And thank you guys for having me. Okay, perfect. I was just going to ask if I needed to put up the slides. Okay. So thanks for having me here. And Andrea, our advanced epidemiologist, is also here just in case we get any questions. She does a lot of our data preparation, so she is extremely knowledgeable about our data source. So I'm just here to explain a few changes that are going to be occurring on the slides and also open up the group to conversation to if we want to make any changes to how this is being presented and if there's going to be anything that's going to be more useful to help you guys make data-driven decisions, because that's something that Andrea and I are passionate about, is providing necessary data, being able to explain it, and being able to help people make data-driven decisions. So this overview slide is primarily the same from what you've seen before, and all of the data from the slide come from Kansas WebIZ, which is our immunization registry. We updated the booster section of this slide, and I'm going to go into that a little bit more on how this calculation is done on the next slide, but I just wanted to make a couple of important notes on the boosters before we do that. So for this overview, a booster or an additional dose is any dose that is beyond the primary series. So it could be any dose, either a Johnson & Johnson or an mRNA that was received after your one Johnson & Johnson vaccine, or any 2 mRNA vaccines. The boosters and the additional doses became approved for certain populations on August 13th of 2021. So if anyone had received a dose beyond the primary series that was prior to that approval date, it's not counted as boosted. And we know the 5 to 11 age group was initially approved on November 2nd, and then the boosters became recommended on May 19th. So we can see that the people who have had boosters in this population group is very small, and that's to be expected. This calculation does not take into account people who are immunocompromised. Because WebIZ is an immunization registry and not a disease registry, we're not able to determine somebody's true up-to-date status for individuals because they have different vaccine recommendations based on these different possible conditions that they can have. So we can say that they've had this many doses, but we can't say that they're necessarily up to date. And all ages that are approved for the vaccine are now recommended to have received a booster after 5 months of an mRNA vaccine or 2 months after a J&J series. And these time intervals are what we use to identify if somebody is eligible for a booster or not. And we can move on to the next slide and dig into how this is calculated. So the booster dose coverage is not being calculated out of the full age group of the population. We're looking at who has received at least 1 dose beyond their primary series among those that are eligible. So using the full population as the denominator here would include people who have not completed their vaccination series at all. And that, in my opinion, it's not as valuable as information. We want to look at who's received it out of who is available to receive it. So it looks a little bit different than it did in the past. And to walk you through an example, we'll look at the 65 plus age group. There's about 750,000 people in that age group in Kansas. 415,000 roughly have had their primary series and are eligible for a booster, which means they're 5 months past an mRNA series or 2 months past a J&J. So we used the 214,981 as the denominator for our calculation, and they're the only ones who should be getting a booster. They're the only ones that are eligible. So out of that, 298,909 have had a booster dose or a dose beyond their primary series. So that's about 72% of that population that's eligible has received a booster dose or an additional dose. If you'd like to move on to the next slide, please. Now we'll take a look at the youth vaccinations. The first thing you might notice when you see this is that one of the graphs does not look like the others. And I would like to say that you are absolutely correct. And we are going to do a deeper dive into the American Indian Alaska Native vaccination on the next slide. But before that, we just want to go over all youth vaccinations, but we will do a deeper dive on the next slide. So a note on youth vaccinations is that the denominator includes the population for everyone under 18, and that includes ages 0 to 4, which we know is not eligible for a vaccine at this time. There are estimates on how large this population is as a whole for the state, but the way our population data comes in, we don't have that for a racial breakdown for those specific age groups. So that's why everything is done for all under 18. And this slide also has changed a little bit. Previously, it looked at the increase from the past 3 weeks, and we've changed it to have the past 3 months. The reason that we've done this is because with the past 3 weeks, there would be almost no change at all. Really, it was like 0.1, 0.2% change points. So we've changed it to 3 months, and you can still see that the increase is quite small, and it generally, for most populations, is still less than 1%. So that actually kind of had us wondering, and maybe something to be discussed is if this is still how you'd like this presented, if there would be a more useful way to present this to you, or if this is still serving your needs. Anyway, we can go ahead and move on to the next slide and discuss American Indian Alaska Native populations. So there are a lot of complexities going on with American Indian Alaska Native vaccination rates. Previously, this was presented as the Kansas WebIZ data added to Indian Health Service data, and then it was presented as a rate. We will not be doing that in the future. Basically, these are two separate data sources, and we don't want to mix them together in that way because there's a couple of assumptions that are made when you do that. And one of them is that the IHS data is not in WebIZ, which some IHS data is in WebIZ. So you're creating duplicates when you do that. That would be inappropriate to do. And it also assumes that everyone who is vaccinated through IHS fits into the American Indian Alaska Native population. And we know that both of those assumptions are not completely accurate. So because of that, we don't want to add them together and present it as a rate, because it really would highly inflate beyond what is actually true for the rate. There are a lot of, we know that the Kansas WebIZ rate is low, and we know that it's not capturing all of the information. Part of why it's not capturing all the information is that not all federal doses are reported to WebIZ, and that there are a lot of people in this population group who will mark down multiple racial groups, and so they get counted as multiracial rather than American Indian Alaska Native. So there's about almost 17,000 individuals in WebIZ that have received a COVID vaccine where they've recorded American Indian Alaska Native as one of their races, but they also have another race mark, so they get considered as multiracial. Whereas there's only about 7,000 that have been vaccinated that have only American Indian and Alaska Native marked as their race. So that's why the rate for American Indian Alaska Native typically looks pretty low, because a lot of people who may be in part of this group from a census perspective are actually being considered multiracial from our data's perspective. We don't want to change what they've marked as themselves because it is a self-identification, but it could look into exploring why it's low. And also, if we were to consider anyone who marked American Indian Alaska Native, regardless as if they're multiracial or not, we could look into what that rate might look like and see what kind of if that's going to seem to be more accurate and give the information that this group is looking for. That's something that we can discuss about doing. We've also talked to CDC about trying to get more information from them, because they've changed a lot on their website over time. So you can't get some of the breakdowns you used to be able to get by state or by county. So CDC right now, their national coverage for all ages for American Indian Alaska Native is at almost 77%. So we're trying to get a Kansas breakdown of this from them, but they haven't given it to us quite yet. So we're hoping to get that for you guys in the future so that you can have all of the information to work with. But we don't want to add the IHS data to the Kansas WebIZ data because we know it would result definitely in overcounting and a lot of duplication. We can move on to the next slide, please. So the adult vaccinations is really a large echo of what I said about the youth vaccinations and some of the changes that were made. We can go over AIAN on the next slide again, but before that, I'll mention that once again, we changed from looking at the past 3 weeks to the past 3 months. And as you can see, it's still, for most populations, only a very small increase in percentage point. For most populations, less than 1 percentage point change and increase. So we can discuss again if that is something we want to continue looking at in this way, or if there's going to be a different way to look at it that is going to be more useful for this group to help make them decisions. If you'd like to move to the next slide. Thank you. So again, with American Indian Alaska Native populations for adults, when it was previously the KS WebIZ data and IHS data added together, it was giving a coverage rate of first doses in the high 80%. And we believe that is artificially high because of the issues that we mentioned earlier. All of those same issues exist for the adult population as well as children. So just something to keep in mind for discussion if we would like to try to present this in a different way, or we would like to look at anyone who is in Kansas WebIZ vaccinated that has American Indian Alaska Native marked for any race and looking at that rate instead of just their only race marked as American Indian Alaska Native. But with that, I'll just go ahead and have some of my discussion points, open those up to the group.
Thank you, Jamie, for the data and also for the presentation. It's very helpful, and appreciate your offer to work with us and adjust the data we look at. Does anybody have any questions that they want to ask now? And you can also email me and we can set up a time, but feel free to ask now if there's any questions.
Dr. Garcia, this is Carly Houchin with IKC.
Hi there.
Jamie, I was wondering about the American Indian and Alaska Native data that you have for CDC nationally, and I'm wondering if that source would be subject to any of the similar limitations that you described for the Kansas data sources, the two sources we had. I'm wondering if there are any overlapping limitations between our state level data and the CDC national data that you presented.
Yes, the issue with the duplications is definitely a potential issue with that, because when we send in our daily data files to the CDC, it's de-identified. So in order to protect the integrity, but what they get in from IHS, we're not able to see that. So there is definitely a potential for duplication with that. So yeah, that is true.
And this is Andrea May with KDHE as well. What we're speaking of in Kansas, the potential duplication is just a small portion of it. In some other states, and CDC has been working with states to kind of work through where there's potential duplication of IHS data.
Thank you, Andrea. Thank you, Jamie and Andrea, so much for being here and for the work. Okay, I would like to pass the floor.
I've got a quick question. Sorry.
Okay, that's okay.
Thank you, Jamie, for the information. And just a quick comment. I love the circle chart at the beginning. Early on in the pandemic, I looked for that every week. But my question is, with the CDC updating their definition of up to date with the COVID vaccine, is there consideration being given to updating how that information is being presented?
Hi, yeah, that's a great question. As I mentioned before, just because our registry is only for immunizations and not for health conditions, we can't say if somebody's truly up to date or not, because up to date is very much dependent upon health conditions, as you know, from immunocompromised and stuff, and particularly in older age groups. So because of those limitations, we don't present it as up to date, because that wouldn't be an accurate picture of what the data can really tell you.
Okay. And so is in that group that I think is described as having received the full series, is that the group that has received the primary series?
Yeah, so the definition of fully vaccinated continues to be a primary series that's completed.
Thank you.
Okay, thank you. So I would like to pass the floor to Dr. Vicki Cully-Akers to introduce our guest speaker.
Thank you, Dr. Garcia. We're really excited today to have Dr. Dana Hawkinson joining us. Dr. Hawkinson is faculty at KU Med Center in the Department of Infectious Disease, and is also medical director for infectious, I'm going to make sure I get this right, infectious control and prevention program at the KU hospital system. Through his leadership with the infection control and prevention program, he supports the collection of data and providing best practice guidance to reduce healthcare associated infections within the KU hospital system, and has provided significant leadership throughout the COVID pandemic. With that brief introduction, I'll hand it over to Dr. Hawkinson to hopefully share his slides and provide a brief presentation. Thank you so much for your time today, Dr. Hawkinson.
All right, thank you. Yeah, I know we'll try to expedite it. I do have some basic science stuff as well as going into the vaccine issue. So let me try and get this shared. And can everybody see that?
Yes.
Looks great.
Okay. All right, so this is a COVID update. It will also be kind of, again, vaccine. I just think that the virology and the basic science is pretty interesting. So we'll just kind of start, no disclosures. These are just electron micrograph images freely available to the public, just of what we are up against and what we are dealing with. And you can just see SARS-CoV-2 here. Obviously, this is colored images. But these are infections in the respiratory epithelium. That is kind of what our body battles when we get infection. Basically, SARS-CoV-2 is a coronavirus. I think we are all aware of that. It is a fairly large genome for a coronavirus, 30 kbs, so quite large. It does have several specific major proteins, including the spike, which we are all familiar with, which most of our vaccines are directed against. Other important ones include nucleocapsid, envelope, and membrane. Obviously, if you have natural infection, you are going to be making an immune response to those other proteins, as well as some of these other proteins that are produced by the virus itself. In general, for the vaccines, we're really looking at developing an immune reaction to spike, and fortunately, it has provided extremely helpful in keeping people safe and out of the hospital. The spike, the major receptor on our bodies, is ACE2, and that is all throughout our body on different organs, including the heart, GI, and of course the lung. So that is, for the most part, what the virus attaches to invade our cells. Now, with Omicron, it looks like there is also another co-receptor called TMPRSS2. Historically, that is what has also helped with infection. However, Omicron, it has shown that it doesn't necessarily need that to infect our cells either. So that's just one minor change from Omicron compared to the other variants. I think everybody continues to wonder exactly where and how did this occur. It is unclear, but it is a spillover, a zoonosis from one animal population to humans. There was a published study, almost 2 years ago now, that showed that maybe SARS-CoV-2 diverged from another bat virus in a large time frame, but somewhere between almost 1950 and 1982. And actually, the virus probably was circulating in bats for decades. When did it jump species? Our best evidence is probably December, but maybe November, or at the very earliest, September of 2019. So really, the primary case of SARS-CoV-2 likely occurred in late November 2019, but not before early November. And again, I think it's also important to understand that there are probably separate introductions of this virus into the human population, because initially what they did see was 2 separate lineages. And again, these are from studies looking at that Wuhan market. Also, what is the origins? We're trying to really figure out where did this come from. Unfortunately, many people, many populations in China, but also elsewhere, live in and around bats. They are working or living or going into the caves for one reason or another. And at that point can certainly pick it up if it's directly from bats. Obviously, a lot of populations around the world have other close contact with animals. So certainly if there was an intermediate host, could have picked it up that way. One study, even dating back prior to SARS in 2018, showed that there was a 3% seropositivity to SARS-related coronaviruses. Again, this was the first SARS infection that we knew about, and that was in 2002, 2003. So people, you can tell 3% is a small number, but it's actually probably fairly large when you think about the population of that province. People are coming into contact with these types of viruses. Luckily, nothing else has really taken hold. A preprint in September looked at other closely related viruses, and they were actually identifying bats in Laos. They took saliva, fecal, and blood samples, and they identified 5 sarbecoviruses. Now, SARS-CoV-2 is called a sarbecovirus. It is a beta coronavirus, is basically SARS beta coronavirus. It's a similar virus to SARS-CoV-2 and SARS. They actually identified 5 that were fairly close, but 3 were even closer to RATG13, which was the previously known closest relative of SARS-CoV-2. And in those studies, they actually identified one that was almost 97% identical to SARS-CoV-2. So we are getting closer to finding more of a direct ancestor. It's really unclear if we will because of mutation, recombination events of these viruses within bats or within other animal hosts. But again, the previous closest known relative was 96% sequence homology to RATG13. However, that is quite a bit in the terms of viruses. That is actually further apart in viruses compared to us to chimpanzees. So I think when you think about the scale of the virus in the genome, that is quite a broad range to be different from one another when you compare it to humans and chimpanzees. Humans and chimpanzees are actually closer related than those two, SARS-CoV-2 and the closest identified isolate is. So again, quickly, the SARS-CoV-2, there was a critical review published in September of 2021, mostly because there have been considerable discussions and debates that this was taken from a lab. This was a lab escape. There's absolutely no credible evidence to suggest that it is from a laboratory. Again, we had talked about there were 2 lineages additionally identified within that additional outbreak and those patterns. And so this would be consistent with the emergence of SARS-CoV-2 involving 1 or more contacts with infected animals and or traders, or most importantly, multiple spillover events. In addition, we know that things have escaped from labs before, and in those cases, all of the documented laboratory escapes have been of readily identifiable viruses capable of human infection, mostly associated because there is sustained work going on in those labs, especially in high titer cultures. However, previous to this, there was no literature at all about this virus. There was no data to suggest any laboratory for research purposes or any other purpose was working on SARS-CoV-2 prior to this. In addition, they did look at antibodies of the Wuhan Institute of Virology staff. And as of March 2020, what we had been told and believe is that all of those laboratory staff were actually seronegative. They did not have any antibodies to SARS-CoV-2. So you would expect even if a laboratory worker had inadvertently got infected and spread it, there would be evidence from antibodies. Other specific and major points are that since its emergence, SARS-CoV-2 has experienced repeated mutations that have increased viral fitness, and we have seen this. We have lived through this now for the past 2.5 years. The very first one that was identified was D614G, which seemed to help with the ability to transmit and infect. And what we see now in all of the variants, they all now have that mutation, and that has stayed in there. Other very notable mutations or changes to the spike protein, and again, all of these currently are in the spike protein, include N501Y, K417N, and then E484K. Those are 3 extremely notable changes or mutations. So overall, currently there is no evidence that SARS-CoV-2 was of laboratory origin. There is no evidence that any early cases had any connection with the Wuhan Institute of Virology. But there are clear epidemiologic links to the animal markets in Wuhan, and we will see that in just a second. There was also no evidence that the Wuhan Institute of Virology processed or was working on that virus prior to the pandemic. So speaking of, there is extremely good evidence. This was a more recent study published, there are actually 2 of them in February of 2022, looking at the origin of SARS-CoV-2, specifically looking at the Wuhan Institute of Virology, doing computations, chronologic analysis, and also taking from some of the World Health Organization report. So there were 1,000 environmental samples from the market that were positive for sequences. Again, these are environmental samples, not necessarily person or animal samples. And And these included lineages A and B, as were found in the World Health Organization investigation. And what this does, as I talked about, this geospatial analysis, absolutely shows a clustering of the cases early on in the market. And also, the suspected A and B lineages evolved in non-humans and spread to humans separately. Again, we had heard that there was no animals that were actually being sold in that wet market, if you will. This is not quite true. We have pictures from earlier in December in 2019, which you can see these animals sitting on top of each other in cages, packed fairly tightly together. Here are the raccoon dogs, possibly implicated as one of the transient hosts of this virus. This image down here is just showing the connection of the Wuhan market and the local cases. So geospatially, they are very centered or clustered around the market. In addition, I think the Wuhan Institute of Virology is somewhere down in this area, and you can see that there's very few, if any, cases involved around there. So that is really the best evidence that we have as far as this is likely did originate around that market. This is just also just showing somewhat of a timeline and the possible etiology of how this all occurred. So again, the bat reservoir, which we do believe, but was there an intermediate host? We can see that here. Is it due to farmed animals, domesticated animals, trapped or killed animals? And then, or is it within the Wuhan market in which they're selling live animals? Here is showing just the actual layout of the Wuhan market. And you can see in some of these heat maps where some of the more densely identified environmental samples were. And then you have these two spillover events of lineage A and lineage B. As you get further on, you start to have this community spread. And obviously, we know with the ease of transport that we have now, and another country is just a plane flight away, the other side of the world, we have international spread. So, but is it mutating? We know, and we have seen this with other RNA viruses. You can absolutely mutate. Is that one of the issues and the problems with vaccination or immunity in the changes to not only spike, but some of the other proteins as well that the virus develops? We know that RNA-dependent RNA polymerase is how we have replication, but we know in that it is not perfect. And so at that point, you can have mutations arise. There is some proofreading to protect against those mutations, but it is obviously not 100%. The other issue, not only those specific site mutations during replication, but also recombination events, recombination with other viruses that somebody may be co-infected with. I think we've probably all heard about this, especially recently we've heard of the Deltacron recombination. Now that obviously is never really taken off, but you can see that recombination event there. And really what we are looking for are changes, substitutions, or mutations that can confer a fitness advantage. Because this virus, although we like to ascribe human attributes to it and anthropomorphize it, is just living through its normal day-to-day life, just replicating. And if it finds some fitness advantage, it will out-replicate all of the other virus variants that are replicating at the same time. So I want to show this very quickly as well. This is from covariance.org. This is just looking at all of the variants. Obviously, you can see here from May of 2020, we are going through. There really weren't too many specific variants that we were able to identify, but as we got to be later in the pandemic, we started to see now an outpouring of different types of variants, and we'll see what these different colors mean. These different colors as we move through time are the specific variants in the United States and the proportion to which they are identified in the United States. Obviously, up here would be 100% of the variants, meaning that that variant is very dominant. We have here just another one. So we are looking now to January of 2022. We see this new variant arise. Just for information, the green is Delta. We've seen some Delta, different variants within Delta, and the red is Alpha variant. And we'll identify these here. Now this is from 4/27, so April 2022, we can see that further variants are identified as we have through Alpha. I believe this is Gamma, Iota, Delta, and its associated covariants. But now we have Omicron, and Omicron has even developed further variants with BA2. And that is what we are seeing here. So as we move through time, we just see that these other variants now have started to take over. And up here is BA2.12.1, which is another subvariant of the Omicron. And finally, one more. We can see that now a couple different subvariants are taking place. I think this one right here is BA4. So this is just to illustrate how now I think we are starting to see these waves. Before we had seen several different kinds, but we are starting to see these waves now of the more fit dominant variants for one reason or another are starting to take over. I have all these identified. Just quickly here, again, the first variant that we really identified was fairly early on in 2020. This was D614G. This soon, because of a fitness advantage, was able to overtake the prior variants or the prior isolates, which did not have this change in the spike protein. What did it show was that you were probably able to infect easier for one reason or another. This mutant form seemed to have these areas on the spike protein more open or erect or able to infect the cellular receptor a lot easier as compared to prior. So you have seen that we have significant evolution after it has began to infect humans. And this mutation is now present, is ubiquitous in all of the other variants that we have identified. So it is a clear fitness advantage. But it's not only about spike. We have other fitness advantage, and I'll just go through this real quick. Things like the innate immune system. And I know we are talking about vaccination, but we have our innate immune system, which is the very earliest part of the immune response that helps reduce bacterial and viral infection. What we saw in alpha was that there was an upregulation of this innate immune antagonist, most notably ORF9b and ORF6. And so when you have that, you have a decrease of that initial immune response. And then therefore the virus is able to actually replicate more until your immune system catches up with it. Omicron actually showed a substitution at the same position that would be predicted to confer a similar effect in the end sequence as well. So we are looking at not only spike mutations, but also other mutations and other proteins that help the virus to reduce our body's immune response to it. And just briefly, Omicron, this is a table from covariance.org. Again, just looking overall at mutations that are common between the variants and mutations that aren't. And as I said before, this D614G was the earliest one. It has now become ubiquitous in all of the other variants that have come after that. Overall, Omicron, we know, has 50 mutations, but over 30 of them in spike. But we know that there's other proteins that are affected as well. Is there a concern or consideration that possible less replication in that lower tract, is that maybe helping to protect us against severe disease as well? That has been one thing that has had a data signal within the literature. So basically, this is just identifying further other mutations which are occurring within the spike. And we know that the subvariants of Omicron even have more different mutations or substitutions than the original Omicron. And the actual original Omicron variant really is not even detected anymore. It's more of BA2, BA2.12.1 as well. So even Omicron has been overtaken. I think this is extremely important because what this is showing here is the original Wuhan strain. When you are looking at the spike protein itself, again, over 30 mutations in spike in Omicron compared to the other identified isolates. This is just how different they are. And you can see this kind of picture here where you have alpha, delta, fairly close to the original Wuhan or Victoria isolate. But you have Omicron really out here. And we think that is one of the reasons why it is so easily evading our antibody response that we get from vaccination or from previous infection. But it's not the only reason. And from this image, again, just another view. If you were looking down on Omicron, looking through here to the middle, you can still see, again, these are fairly closely related as compared to Omicron, which is in its kind of in a category or an area all of its own. I just like this image. I think it's pretty fun to look at. This is just a computer simulation, just looking at spike on the virus itself. And these little things that are moving on spike are just glycosylated moieties that are also maybe helping to have some immune evasion. This is just a very good rendering of the spike protein. The main point of this slide here is that we have these hypervariable or easily mutated areas on the spike protein. Now you're looking at it from the side view, so it would be attached to the virus here. You're looking at it down from the top, so this is where it would really be binding our ACE2 receptors. The main point of this is what we're looking at right here with the conserved versus the variable. Once these changes quite a bit, we know that our antibodies are so razor specific to these areas that they are easily rendered useless if there are even slight changes. But in these areas that are more conserved, in these dark areas, we know we still get antibody binding, which does help. Not necessarily neutralizing all the time, but certainly it does help. But even more important is that T cell response. And so our T cells are still able to recognize these really highly conserved areas within the spike. And as we will see in just a little bit, that is very important for protection against severe disease. So what about immunity? So T cell responses, we know that T cell responses are binding those structural antigens or those areas on the spike. They are broadly recognized. Also, again, if you are infected, you are recognizing those proteins as well. But there is a high number of those epitopes or those areas that T cells can recognize. They're estimated average 19 class 2 and 17 class 1 epitopes per person genome-wide, and 9 if only the spike protein is considered. So certainly we have a lot of those in the virus itself. But even on the spike, there is a considerable number of those epitopes. So overall, it appears unlikely, and this is again from July of 2021, almost a year ago, it appears unlikely that the new variants will escape T cell recognition at either the population or the individual level. And this is exactly what we have seen. And I just want to point this out. This is just a cartoon of the immune response. So you have infection. You have that innate response that I had talked about to the virus, those very early interferons and chemicals that our body secretes to help reduce the viral replication. From there, you have the dendritic cell, which is uptaking the viral antigens, the foreign areas of that virus. You are then creating T helper cells, T regulatory cells, cytotoxic T cells. These are extremely important to kill infected cells. Induction of antibodies, and then of course the B cells and the plasma cells, which are all creating these antibodies. As time goes on, you develop memory T cells and B cells that can be recruited very quickly should you see that infection again, to help already have that response that is there, but able to expand that response in a robust manner, mostly again to protect against hospitalization and severe disease. I just like this cartoon here of the virus with the spike protein and antibodies attached here.
Dr. Hopkinson, this is Courtney Hayden. Thank you so much. I feel like I'm learning more, even though I've been working in this, feels like since the beginning. Just want to cue that that we're at time, but I think that Glenda's question is really fantastic because it ties us to sort of the cherry on top that we want to get to before we switch topics. So
Yeah.
her question is sort of high level, maybe basics, how this relates to a person's vaccination and boosters and then becoming infected. I also think Vicky, Dr. Jimenez and I will take offline. Maybe this is a conversation that we need to continue another time.
All right. Okay, let me just give a couple more slides. So this is the very first slide that we have seen. This was from the Pfizer-BioNTech initial vaccine brief. And what does this show? This shows vaccines work. And this is the placebo, where people who didn't get the vaccine, these people got the vaccine. And basically what we saw was a significant reduction in infection from the vaccine. As we continue to move on, we have continued to see that the vaccine effectiveness for full vaccination to prevent COVID hospitalization remains extremely high in that 85 to 90% range as well. And so this is very fairly new data to continue to support the use of vaccines for that. We know that we have the mRNA vaccines, the J&J vaccine, and now Novavax has been authorized as well. Basically, I was saying vaccination also helps reduce the chance of long COVID. We have seen very good data to continue to support that as well. So if you are infected, it is continues to be important to get vaccinated even after infection. This will help reduce your risk of long COVID. And then this is a very new published study looking at transmission and infections, SARS-CoV-2 shedding in the vaccinated and unvaccinated individuals. Basically, what this shows was that fully vaccinated individuals showed viable virus in cell culture until 4 days after symptom onset, as compared to people who were not vaccinated or partially. They continue to have live virus cultured even up to 8 days. So we start to see now further evidence that vaccination also helps reduce transmission because people aren't shedding live virus as long. And then this is just talking about myocarditis. The chance of myocarditis is extremely higher with infection itself as compared to vaccination. And protection against multi-system inflammatory disorder, especially in children, we know that vaccination continues to provide excellent protection against that. So that's the Wuhan market. Sorry we went over, but if there's any questions, I'm happy to answer those.
Thanks so much again, Dr. Hawkinson. So I am going to say, I think today has been incredibly beneficial in that we had a couple of ideas, data, long COVID, a little bit of immunology review, and I think it's been incredibly helpful. So I would ask that everyone for your questions, your thoughts in the chat. And I am going to give the remainder of this meeting to Giovanni Gone. I will say we had topics we were going to chat about. We normally have a closeout, but I want to give her that time. And we're going to go to the drawing board and keep the conversation going. So Giovanni, I won't do a long intro because you started to intro yourself earlier, which is fantastic. So Giovanni is the Chief Administrative Officer of Genesis Health, which is an FQHC in Southwest Kansas. And on a personal level, she is the friend who always makes sure that I have a sandwich to eat at vaccine events. She has a big heart and does more for the community than I even know how it's possible. Thanks for being with us, Giovanni.
Thank you, Courtney, and thank you for the invitation. It is great, and I always love the opportunity to talk about a few projects that we have going on in Western Kansas, specifically to address COVID hesitancy in testing and education. I think that as we talk about, vaccination and testing, there is always an important piece that goes with that, and that is education. Western Kansas is known for their migrant, immigrant, and refugee communities. We have a lot of families that migrate because our area is known to have beef plants, dairies, and feedlots. And so we see a lot of families migrating from place to place to find employment. The other big aspect of our area is that we are an immigrant community. We do see families from different parts of South America, Central America, like Honduras, Venezuela, El Salvador. And so we have to kind of be aware of that cultural, those differences culturally as well. And then we are a refugee community. We do have families that have been placed in this area by Catholic social charities. We see a lot of Afghanistan families, Somali, Burmese, Vietnamese communities. And one of the biggest barriers is, of course, language. And with that, this year, we had an opportunity to receive some funding through the PAVE grants. And of course, the PAVE grants addresses, health equity and how we can reach to those hard to reach families and communities that are within our, within the places that we serve. Next slide, please. So Genesis Family Health is a federal qualified health center in rural Western Kansas. We offer services to everyone, whether they have insurance or are uninsured or on CanCare. And we have clinics in Garden City, Dodge City, Liberal, and Ulysses. But we do see a lot of patients that are in the more frontier communities or in between these communities. Next slide, please. Goals with this PAVE grant, we kind of identified 4 things that we wanted to do with the money. First, we wanted to be able to pay for out of regular hour vaccinators. Now, what I mean with this is because we have feedlots, dairies, and different employers that have different shifts. Sometimes we've seen that either they need vaccines or testing early on in a day or later on in the day because there's different shifts. People are coming in and out of the beef plants, and it makes it easier for access to care for them to do it at different times of the day. So part of our budget went to vaccinators that could actually be available during those time of days. The other purpose of the grant was to get more certified test administrators. And with that, a little bit of education. We've noticed that during those peak times when we had COVID, there was a lot of need to test. And unfortunately, because of staffing, being sick or being very short staffed, we had to find a way to find more people that were trained to do those tests. And so we started kind of a little bit of training with some of our CNAs in order for them to be certified and be able to provide those tests. We did a lot of partnering with the school districts and with the local community colleges to ensure that someone was available to provide those tests whenever students from out of state came in or checked in at the local college. There was somebody available to provide that COVID-19 test to them and to ensure that they weren't infected as they were coming in from out of state. Part of our budget was also to purchase iPads. And maybe that's a little bit unusual. And maybe you're thinking, well, why would they need iPads for this? The iPads are mobile. And so as we plan drive-by COVID-19 shots, vaccines, it was so easy to be mobile, be able to sign that consent agreement, be able to do data collection. We also utilize these iPads to do a very quick social determinants of health questionnaire because we've noticed that as families came by, there were other things that they were needing help with. And there were other social determinants of health that we were able to assist them with. So this quick survey allowed us to follow up with the family, provide additional resources, or follow up with a provider so that they could come into the clinic and follow up if they had any adverse reactions to the vaccine. So iPads were amazing. And then the last piece with this grant was translators. Because of the many languages that we speak here in this community, we understood that information had to be in their language. We talk about education, we talk about, misinformation that goes on, but when a person hears that information, that correct information in their language, it just makes more sense to them. And so we understood that we needed, those Burmese translators, those Vietnamese, those Swahili, to make relevant information and be able to understand that information on their own languages. Next slide. And this will be my last slide, I promise. So the very last piece of this, we focus a lot on community outreach, meeting the people where they are at. Sometimes I think we focus on, come and get your vaccine, but we focus on let's go there, meet them where they're at, and provide them the vaccine. And so a lot of community outreach. We do always events, and this is one of the events where we participated. This was a Cinco de Mayo celebration, and as you can see, people loved it. And on the table, we had some in-home COVID-19 tests. We had a nurse available to make the vaccine available, and we also provided tests for those that wanted the test. We meet them where they're at. If there's a community event, if there's an employer that needs anything, we are there supporting them at their place of employment or at the event that they're attending. We try to always be relatable. People will feel more comfortable to come and ask questions when they feel comfortable coming and asking those questions. And so we always try to be relatable to them. We always offer information that it's easy for them to read and understand. Dr. Hawkinson did an amazing job explaining everything, to do with the vaccine. But when you're out there trying to talk to some of these families that maybe only have a 5th grade education, that is hard for them to understand. And so we always try to make it easy for them to understand and disseminate correct information so that they have correct facts. We always provide other resources. So if the family is needing anything else, such as addressing like food insecurity or transportation or interpretation, we always offer something that they can go back to. And then we always tell everyone, do not make it an argument, especially when we're out in the community. There's always people that want to stop and argue, or, they're very opinionated as to, the vaccine. We are always there to educate the community and provide factual information, and not to engage like in an argument that can turn into a situation that we shouldn't be in. And so with that, I don't know if anybody has any questions.
Thank you so much, Giovanni. Your work and just how you really put the needs of the community first just are always so humbling. So thank you. And I'm sorry that we've kept people a couple minutes over. So if you have a question, if you put it in the chat, I can communicate it to Giovanni. And I want to thank you again for spending this hour with us and your flexibility with our agenda. I want to thank the 3 guests who shared with the group today. And also, if you do have feedback about the vaccine data, please email me. If you don't mind, also please fill out the survey so we can find out what your preferred meeting days and times are going forward. And once we know that, we'll send out an invite for July. So hope to